Okay, so welcome back for the next session, which we're covering override anomalies. And in a sense, for override anomalies, for many of us, a real challenge is once we see the override is actually trying to work out which of the top three it is, in a sense: Tetralogía De Fallot, double outlet, right ventricle, common arterial trunk, and they all have their unique differences in terms of prognosis and management. So we've devoted a whole session to that with one or two case studies towards the end of it. So to get the ball rolling, I'm going to start with Tetralogía De Fallot, which is one of the most common outflow tract anomalies that we see. And no one tetralogy looks the same as the next. So in a sense, what I thought I'd do is just to go through examples of Tetralogía De Fallot and maybe ask you a question or two, whether you actually think this is just a normal variant or a malaligned VSD or Tetralogía De Fallot, and what distinguishes one from the other. The talk is divided into the following sections. So I just discuss the facts and figures, and then just go through with some cardiac sketches, which hopefully gives an understanding to those on the more entry basic level of the 700 or so we have online. And then to cover mild, moderate pulmonary stenosis, pulmonary atresia, and then just a few words about absent pulmonary valve syndrome. And then probably the most difficult aspect of all of this, and probably what's written most about in the antenatal literature, is prognostication and predicting outcome. And it's, I have to say, just reading and preparing for this talk, I found it's just a monster amount of information that's out there on the antenatal prediction of outcome in babies with Tetralogía De Fallot. And it's not, the waters are a little bit murky. It's not crystal clear, but I hopefully condense it into three key categories in assessing what is the prognosis when you're faced with a diagnosis of Tetralogía De Fallot, isolated or otherwise. So it's, in a sense, Tetralogía De Fallot is that there are four components, and the right ventricular hypertrophy is not seen prenatally, so it's really prenatally the trilogy of Fallot with the VSD, aortic override, and pulmonary stenosis. So if we look on the facts and figures, and this is sort of facts and figures you can get in any textbook, so I'll be brief because you can read this anywhere. But I think it's important to remember in Tetralogía De Fallot, it's one of these cardiac abnormalities that has a very strong association with extracardiac abnormalities. And it also is a cardiac abnormality that you need to look for coexistent cardiac abnormalities. So if you look at it with Tetralogía De Fallot, you'll have those which we can pick, which would be the ASDs, PFOs, which Ravi will talk about a little bit later. And then about 25% of those will have a right aortic arch. I always worry about Fallows with the right aortic arch because that, for me, is a worse prognostic group, more likely to be a pulmonary atresia. And then 10% of them will have a persistent left SVC, and we might pose the question, well, does that make any difference in terms of surgical management after birth? And then always look for an AVSD. If you ever see an AVSD with Tetralogía De Fallot, the question is, well, that's going to be Down syndrome. At least historically, that was it. AVSD and Tetralogía De Fallot. So again, that's a very strong association, which you go straight to genetic testing. Seldom you hear much being spoken about in terms of the coronary artery anomalies that do exist in up to 5% of babies with Fallows, and they're just a little bit of a nuisance in a sense. I want to say a nuisance, but they add complexity to the surgical management, and that's something we might, if we have time, to discuss during Q&A. In terms of the genetics, we sort of touched on it today. I'll be brief about it, but again, it's one of those clear-cut cardiac abnormalities, unlike, for example, TGA or an aberrant subclavian. It's an abnormality which we get into discussing invasive genetic testing. And it's the common trisomies, and of course, 22q deletion. 15% of Fallows will be DeGeorge syndrome. And then in terms of our monogenic disorders on published data, which, as Asma made the point, it's early days, but somewhere in the order of 10 to 15% of these will have monogenic syndromes as the basis for it. So do we go straight to that or not? Well, we've discussed that. I think in terms of Tetralogía De Fallot, the way, as an obstetrician thinking about it, I think it is as many babies with Tetralogía De Fallot, most of them are born pink. They're the pink Fallows, and they're the ones that go home with the mums, and they're operated on 6 months later. And the ones that we worry about, in the sense of the blue Fallows, the ones that are cyanotic. You know, Tetralogía De Fallot is a cyanotic Fallows, is one of those common causes of cardiac causes of cyanotic heart disease. But most of the Fallows that we see have got good-sized PAs. And having said the word PAs, pulmonary artery, everything to do about fallows, in terms of the classification of fallows, the diagnosis of fallows, the management of fallows, all circles around the pulmonary artery. And the biggest problem, in a sense, with fallows in the pulmonary artery is the pulmonary artery may look great at 20 weeks. You know, you do Z-score in your pulmonary artery, and it may be plumb normal. But then by 35, 36 weeks, the baby, you know, may have evolved to a pulmonary atresia or less likely to a severe degree of fallows. And unfortunately, those machines don't come with a crystal ball. And in a sense, the question is okay, can we prognosticate and pluck out the fallows that are the ones that are going to be nasty fallows, they're going to be the cyanotic, not the pink fallows. And in a sense, that's why there's an explosion of the antenatal literature in trying to prognosticate prenatally, plucking out which are the ones that are going to be problematic. Because if you look at the actual outcome for fallows, for those, the blue fallows, good-sized pulmonary artery, it's a single operation repair. The outcome for these babies is very, very good. So it's one of those conditions in a sense that it's, I see optimistically in the sense of seeing good-sized PAs in those. In terms of the antenatal surveillance of it, I will come back to that, but again, there's no one formula as to how we manage it. But the key thing that we do is we need to know the size of the pulmonary artery and monitor those during pregnancy, and Z-scoring, in a sense, is the way how we do that. So if you look at it and break it down, about 80% of them are pulmonary stenosis, 20% of the pulmonary atresias, and these are the nasty ones, but pulmonary atresias, particularly those who've got multiple arterial pulmonary collaterals with no native pulmonary arteries. I mean, the figures on it are appalling. You know, 80% of them will be dead by 20 years of age. I mean, it's a terrible statistics, but for us it becomes very important in terms of, you know, making a diagnosis of fallows to see, are they in the group of pulmonary atresia? If they are in the group of pulmonary atresia, do they have native pulmonary arteries, or are the lungs solely receiving their supply through multiple arterial pulmonary collaterals? And then there's absent pulmonary valve syndrome, which, I don't know, I've been doing this for 30 years, and I saved every case since I've started, and I have 4 absent pulmonary valve syndromes after 4 years of scanning. Ravi, I'm not sure how many you have, or Dario, but it's a rare condition. But we are picking it up far more frequently in the last 10 years because of first trimester diagnosis. And again, it's a fairly straightforward in the first trimester, and many of them don't survive into the second trimester of pregnancy. In terms of cardiac sketches, just to run through this, again, cardiac sketches, the way I do this is just as according to the ISOUG guidelines: stomach, 4-chamber, 5 right ventricular outflow tract, and the 3-vessel tracheal view. So what may you see in a 4-chamber? Well, for many of fallows, you'll have a completely normal 4-chamber. You won't appreciate anything. For those, you may see in a 4-chamber a ventricular septal defect, and in 25% of them, you may see that there's a right aortic arch. With regard to axis deviation, 45% of them will present. And in fact, in the first trimester making a diagnosis, this is how we pick them up in the first trimester, because the sonographer sees the heart's lying on its side, the apex at 3 o'clock or 9 o'clock, and then the penny drops. This is not normal. In terms of axis deviation, again, these are the groups, so in a sense that we worry more about, because nice paper by Alfred Abahamid reporting on the association with this left axis deviation with pulmonary atresia and neonatal demise. So it's one of those things which we worry about. So it comes really to the 5-chamber where we make the diagnosis for most of these. If you go to work tomorrow morning and you see a perimembranous VASD, of course, the first thing that comes to your mind is you say, I wonder, is this a Tetralogía De Fallot? And what you do is you look at those 5 sections I mentioned about the LVOT, and you ask yourself the question, if it is discontinuous, is it actually malaligned or is it aligned? Well, you know, that's a very subtle thing. It's a very subtle finding. It's nice to draw a diagram where you show it's perfectly aligned, but there's a diagram that shows you that it's malaligned. And once you get to the point of seeing a malaligned VSD, you're worried because your sense is falling into that category of Tetralogía De Fallot, and this is something that may evolve as the pregnancy progresses. And if you look at this case in the middle, where you've got more than, when it's say up to 50% across by sort of classification definition, it's a Tetralogía De Fallot. It's more than 50%. The aorta rising from the right ventricle then becomes a double outlet right ventricle. But in those particular categories, there's not a whole lot difference in terms of the post-surgical repair and management of these babies. And then on the last one, you may see that there's turbulent flow. And you can see that in 2D, particularly for those of you who use stick 2D in first trimester. You see that high volume flow in the aorta in routine imaging. And in the vessels, coming up to the 3-vessel view, You can have mild pulmonary stenosis, moderate pulmonary stenosis, and then pulmonary atresia simply refers to failure of flow across the pulmonary valve. Now, for many of these babies with pulmonary atresia, it's early onset. There will be no pulmonary vessels, whereas in late onset, you may see flow. And then there's absent pulmonary valve syndrome, but these are very rare. Three-vessel tracheal view. Remember I said in screening for the heart abnormalities, the four-chamber view and the three-vessel tracheal view are the three most powerful. So you will, while you may not see it in the four-chamber, you move to the three-vessel tracheal view, and you will see that when you look at this level, they should be the same size. The vessel closest to the trachea is the transverse aortic arch, and the pulmonary artery is small. Okay, so now you're going to say, there's a differential on that. And if you see there's a reversal of flow, that's what you will see with pulmonary atresia, if in the scenario that the pulmonary vessels are being perfused in a reverse direction through the arterial duct. And then there are those where you actually see no vessel, you just see a dilated aorta, and in this case with a bilateral SVC. Now you start asking the question, well, where are the lungs getting their blood supply? If all I can see on a three-vessel tracheal view is the aorta. And it's particularly challenging if it's a right aortic arch, because the duct sits inferior, and that requires a lot of experience to recognize reversal of flow in the duct when it's sitting inferior to the right aortic arch. But it becomes so important to establish where are the pulmonary arteries coming from, how are they being perfused. Because if you're in the scenario where the pulmonary arteries are actually receiving is applied through native pulmonary arteries that are going to the lungs into the top three, these carry a much better prognosis. Compared to the lungs that are being supplied, anything from the intercostals to the subclavians to the descending aorta, these multiple arterial pulmonary collaterals are a surgical nightmare in terms of repairing, and these are the babies that carry a terrible prognosis. So let's run through the cases. So you're faced, in a sense, tomorrow morning with a scenario, and I'm going to show you 4 cases and ask you, would you pass these off as being ventricular septal defects, or would you pass them off as being a Tetralogía Fetal? And you say, well, what's the difference between the two? And I'll come to that. And I say, well, this to me has got 2 features of a VSD, dropout and edge enhancement, proximal edge enhancement. And when I look at that, I think that's malaligned. But you can choose a frame on that when it looks aligned, and it's challenging. So what do you do to get the real answer? Well, the answer is you move to color. And you use a cine loop, and you're looking for a wash of color to work out whether this is a perimembranous VSD. And then do it with stick volume analysis, and you can see that bidirectional flow. There's no question this baby has got a VSD. The question is does the baby have Tetralogía Fetal? So in a sense, you want to make a call at Tetralogía Fetal. The pulmonary artery is ultimately where you're going to say, is it smaller than the aorta? Well, I've frozen an image here, and if I look at that pulmonary artery, it's larger than the aorta and the SVC. So is it a case that this baby just has a malaligned VSD with a good-sized pulmonary artery? Well, the next step I will want to know is there laminar flow across the pulmonary valve? And then I want to Doppler the pulmonary valve to see the 100-centimeter rule as a starting point. Is it more than 100 centimeters or not? So in this case number 2, I look at this image and I say, that's a textbook override, 50% across. This has got to be a Tetralogía Fetal, high-frequency transducer, seeing a 50% across. You're almost wondering, is it in fact double outlet right ventricle? Well, have a look. Here you have the trouser leg appearance, that typical appearance where you see the aorta is perfused by both the left and the right ventricle, hence the trouser leg appearance. So you expect you're going to see a really small pulmonary artery. Well, when you sweep up to the 3-vessel view, you see a good, chunky, normal-sized pulmonary artery with laminar flow. And look at the size of the pulmonary artery. It's absolutely plumb normal. And for those of you in the room, you probably also appreciated, as you look at this on the 3-vessel tracheal view, you have a bilateral SVC. There should never be a vessel beside the pulmonary artery. So here you have a aorta lying 50% across, and when you look at the pulmonary artery, you have a normal-sized pulmonary artery and a bilateral SVC. Of course, for me, I say, oh, crikey, hang on. It's got an aortic override. I've already told you 15% of fellas have got a bilateral SVC. This is sure going to be something that's going to evolve into a Tetralogía Fetal. In this case here, when you look at this, on a sweep up from a 4-chamber view of heart, you appreciate that the pulmonary artery looks small. My screen's just frozen. Just bear with me for a second. And coming across on this, I can see that the pulmonary artery in this case looks of a normal size, but when I pulse Doppler across the pulmonary valve, I want to know are the velocities increased. Now, I don't go to Rizzo's chart. I Z-score it. Now, these systems, particularly that system we're scanning on, it's so nicely laid out in terms of Z-scoring. Let's open this one. Hopefully that will get me back to where I want to be. So I look at the pulmonary artery velocity on this case. Here we go. So I look at the pulmonary artery velocities and I say, okay, the 100 centimeter rule, it's less than 100 centimeters. So when it's less than 100 centimeters, then the next step I want to know is what's the Z-score on this? But before I even to Z-score that, I listen to compare basically the vessels to each other. But look at the size of the pulmonary artery, it looks fine. And the last case I show you, this is, if you look at it, you see dropout, edge enhancement, and with color Doppler, you see turbulent flow, you see the malaligned VSD. And this is the view that you want. You come across on the short axis showing the tricuspid valve, the pulmonary valve, and here on the short axis view, you want to know, is there any obstruction to the right ventricular outflow tract? That's when that view becomes so important in terms of looking at Tetralogía Fetal. Because if I show you these 4 cases, at the end of the day, there's a spectrum before you get down to the next chapter in my talk, which is the standard lay-down Mézières Tetralogía Fetal. There is a spectrum of subtle findings before you get to a mid-trimester diagnosis. And you need to go through the motions of one, comparing the size of the vessels, looking for associated abnormalities, bilateral SVC, looking for laminar flow across the pulmonary valve, Doppler assessment to see if it's greater than 100, and to work out whether you are actually looking down the barrel of phallus. Because if you're not, the next step is you're going to have to monitor to see whether it evolves over time. And by way of comparison, I say to you, okay, so this is the aorta here in this scenario, sitting astride the ventricular septum with velocities in the order of 50 centimeters a second. And you can hear, in a sense, almost the higher velocity in the pulmonary artery. Remember, with regard to the pulmonary artery and Tetralogía Fetal, for many of these are infundibular obstruction. It's basically a muscular obstruction at the bases of the pulmonary arteries that leaves the right ventricle. But there is also pulmonary stenosis, which is valvular pulmonary stenosis for many of these fellows which coexist, and it may be a combination of both. The next group you're going to find much easier, because when you look at this on a routine scan, you go to work tomorrow morning, a patient at 24 weeks of gestation, you sweep to a 5-chamber view, there's loss of continuity, the aorta is sitting astride the ventricular septum, you've got hyperdynamic high volume flow because both ventricles are filling, and then you go to your 3-vessel view, you have these small pulmonary arteries, and here's your branch pulmonary artery here on either side. So that's a typical example, and we chart and record at that point in time what the sizes of the vessel is, and at the same time we Doppler, and looking at the velocities here if we're getting over 120 centimeters a second. Textbook Tetralogía Fetal at the mid-trimester. In terms of color Doppler examination, we look to see where the duct inserts, was one of the things that's very useful in the first trimester is seeing the proximal insertion of the duct. So I showed you today how the normal 3-vessel tracheal view looks at V sign, here's your trachea and SVC, whereas in Tetralogía Fetal, you have proximal insertion on the undersurface of the aortic arch, and you have a Y configuration, and that can be a very useful clue in the diagnosis of Tetralogía Fetal. And then with stick volume analysis, you can see how much smaller those pulmonary arteries are when compared to the aorta. But still, for a patient who's at 28 weeks of gestation, these are good-sized pulmonary arteries. And again, coming across on a short axis, in this case, when you're looking, it's exactly this point here where you're looking for the obstruction of the anterior deviation. This is your pulmonary valve, this is your tricuspid valve, this here is your right ventricle. So again, get that point of the right ventricle, fan to the neck, rotate your transducer to get that view where you show the 3 valves all in one section and look for anterior deviation in the infundibular region of the pulmonary artery. The last group, Tetralogía Fetal with pulmonary atresia. For many of these, you will find that there's axis deviation. For many of these, you will find, when you look at it coming across, that the aorta is in fact much more dilated, which sort of makes sense, right? Because it's receiving the output from both the right and the left cardiac ventricle. So when you see a really juicy, enlarged, subjectively, aorta, you'll jump to the diagnosis in the sense of either a common arterial trunk or pulmonary atresia in the setting of Tetralogía De Fallot. Now you ask yourself the question, where does the blood supply come from in this baby? So in a sense, if there's no flow across the pulmonary artery, essentially the blood comes out of the left ventricle, travels through the ascending aorta, turns the corner around the duct, goes down to the level of branch pulmonary arteries, and in a reverse direction, both lungs are perfused. Now that's good because you have native pulmonary arteries in terms of surgical repair. But if you look in your three-vessel tracheal view and you see no reversal of flow, you can't find it, then you're left in the situation of saying, okay, I need to find where are the collaterals. And they can be extremely challenging to identify the arterial collaterals. And these are the terms of the breakdown of what the proportions are. And in a sense, these are the ones that have, I say, those figures I gave you as being a terrible prognosis. So when you see, and you've made the call in this case of a ventricular septal defect with the aorta sitting astride, you can see the aortic valve, and then you sweep up from a four-chamber view of heart, you're expecting to see forward flow through the pulmonary artery. You're not. You're seeing here reversal of flow. And then if you go on to a sagittal section of this, again, remember the trachea? This is the aorta, pulmonary artery. You can identify exactly what is the vessel that's showing reversal of flow. But it's really to this point here where you go on to sagittal imaging. Now you can see that this is the ductal arch with the reversal of flow here in a baby with Tetralogía De Fallot. And you'll find some of these are quite serpiginous. I mean, you look at this here, here's your ductal arch. Actually, just let me show you a four-chamber first. So here's your descending aorta, left atrium, left ventricle. You freeze frame, and then you sweep to the head and neck, and then you see no pulmonary artery, and you see a big dilated aorta. There's your trachea, vessel closest is the aorta, and your SVC, and you see no arterial duct. And then you sweep onto a sagittal section. And for most of these, you will see that it has a straight course, but this is quite a serpiginous course to the arterial duct. And then if you look on that three-vessel tracheal view, you can see, particularly for the right aortic arches, that it's sitting inferiorly. I mentioned earlier on the value of looking at a four-chamber view of heart, because on a four-chamber view of heart, in the setting of Tetralogía De Fallot, if you look with low-velocity settings, you can catch the arterioles coming directly off the aorta. And in a first trimester scan with the stick volume analysis, you can see multiple arterial pulmonary collaterals coming off this fetus with pulmonary atresia at 13 weeks of gestation. So don't forget to look at the four-chamber view of heart. Lastly, absent pulmonary valve syndrome, rare condition. It's not just a condition of, I hope my battery will last me long enough. So yeah, it's not just a condition of, from the point of view of a major cardiac abnormality. In a sense, they have a real problem in terms of their airway. And many of these babies require tracheostomy and positive pressure airway ventilation afterwards because of the pressure of the pulmonary arteries on the airways. But in a sense, in terms of what is the condition, well, it's basically either absent or dysplastic pulmonary valves. And in a sense, from making an antenatal diagnosis of it, it's completely different to anything I've just described. You look from a four-chamber view up to a right ventricular outflow tract, and you see the seesaw motion, equal volume of forward and reversal of flow across the pulmonary artery. In the first trimester, we see them, and there's no dilatation in the pulmonary artery. In the second trimester of pregnancy, you see this gross dilatation. And when you first look at a four-chamber view of heart, it sort of strikes you, you say, crikey, is there an left atrial aneurysm? And then when you put it on colored Doppler examination, you see that seesaw motion of high volume of flow. And these babies, as I say, carry a very poor prognosis. If you look at some of the larger series that are published of these, for many of these that choose not to continue the pregnancy, it's one of the abnormalities when you ask what are cardiac abnormalities that result in fetal death in utero. This is one of them. And then if you look at in terms of afterwards the neonatal death rate 10%, and then overall out of the study of a large series of them, only 27% of these are survivors. And in terms of, again, when looking at these, you need to consider exactly as with Fallot's, the possibility of 22q deletion. In fact, it's even higher. It's not 10 to 15%, it's around 20 to 25%. So an even greater chance that you're looking at 22q deletion. Interesting, though, this absent pulmonary valve syndrome has also been described, not in the setting of Fallot's, but with an intact ventricular septum. They have not been reported to date as existing with 22q deletion, which is interesting reading. Graphically, this is how it appears. Axis deviation Dilatation of the right ventricle with significant regurgitation. The pulmonary artery is not that dilated, which sort of makes sense because of this massive volume of flow. In the first trimester, you just see that bidirectional turbulent flow. In the second trimester, you see gross dilatation. And for most of these, there is no arterial duct. So you just see a big dilated aorta. In the sense of seeing an arterial duct, you need to question whether it's in fact with an intact septum. So you do a four-chamber view, you see this aneurysmal dilatation of the branch pulmonary arteries, both here and here, the right and left pulmonary arteries. And then on color Doppler examination, you see this high volume flow. You can't miss it. It's a very, very striking diagnosis. But it may be subtle. Remember, they're not all presenting like that. So this is a patient at 20 weeks of gestation where you see the aortic override, 50% across the ventricular septum. Now you sweep, you're thinking, I'm looking at Tetralogía Fetal with pulmonary stenosis. And when you look, you're expecting to see a small pulmonary artery. And the next step you look at is you turn on the color. As you see the color magnified, you see the volume of regurgitant pulmonary valve regurgitation equals the forward flow. When you Doppler that, you see the equal volume of bidirectional flow of absent pulmonary valve syndrome. So this is the Doppler appearances of how it looks. So this, in a sense, would carry a better prognosis when compared to the absent pulmonary valve syndrome with the gross dilatation. But these are a small proportion in terms of what has been published in the world literature. There are variations, remember, with Tetralogía Fetal, I said exists with other things. If you ever see it with an AV canal defect like this, you need to think of trisomy 21 Down syndrome. Looking on the three-vessel view, you see the small pulmonary artery. And as we now enter this new world, and we've just had that discussion of genetic testing, when we looked at this baby and came back later, it also had agenesis of the corpus callosum. So we had agenesis of the corpus callosum, an AV canal, dextrocardia, but the baby also had hypertelorism. And of course, we did chromosomes on that because it was a first trimester diagnosis. The CMA was negative. We did the chromosomes on back, came back with a monogenic disorder result on this. So, you know, in terms of as an example where first trimester diagnosis made a very different impact on how this pregnancy was managed because things were all sorted out by 16 weeks of gestation. Right, a few words to finish up in the Tetralogía Fetal in the first trimester of pregnancy. If you look at the detection rates from Sinjalaki study of 100,000 pregnancies screened in the first trimester of pregnancy, about 40% of these are picked up in the first trimester, 54% in the second trimester, and then a small proportion. Again, many of these will be malaligned VSDs that progressed into fellows. And of course, there are some which we miss. So in terms of, if you look at the first trimester detection of Tetralogía Fetal, it has been reported on small numbers in the past. This is probably the most interesting paper because it talks about how in the first trimester of pregnancy, it evolves when you see minimal pulmonary stenosis. By the mid-trimester, they may have pulmonary atresia. So very much an evolving lesion from the first to the second trimester of pregnancy. How do you pick them up? Well, the point I made earlier on was you see axis deviation. So here is the heart lying on its side with the apex at 9 o'clock. And then you take out a high-frequency transducer, you rotate the probe 90 degrees, and when you look at the left ventricular outflow tract, you see the aorta sitting astride the ventricular septum in the fetus at 13 weeks and 5 days. And then you're left with the situation trying to work out, is it any of the other three, common arterial trunk, or a double outlet right ventricle? So stepping to the next step is to go to a vaginal scan, and this shows the typical appearance of the high volume flow, which you can appreciate on 2D as well as on color Doppler. And then when you look at a stick volume analysis, you see that typical sort of question mark configuration of that dexter position of the aorta when you look at it on a 5-chamber with stick of a Tetralogía Fetal. And here, similarly, look to your 3-vessel tracheal view, you can see that there's a right aortic arch. So fetus with pulmonary atresia with a right aortic arch. The Y configuration, I mentioned the importance of this. So you look at a 4-chamber view of heart. You can see the heart's on its side. Swept up to the 3-vessel tracheal view. You see the big aorta, but it's the way the pulmonary artery inserts proximally in a fetus that had absolutely no other markers of congenital heart disease. So a Y configuration on a 3-vessel tracheal view is a very, very useful marker of Tetralogía Fetal in the first trimester. What we don't know is what's the false positive rate. because I see a significant proportion of patients coming through with the sonographer say, Simon, I can't get the V sign. All I can get is the Y sign. Does the baby have fallows? And I go and I step in the room and look, and it's completely normal. So it does depend on the angle. We don't know what the false positive rate is. In terms of with tetralogy or with pulmonary stenosis, looks exactly the same. You can see a four-chamber view of heart. As you sweep up, you see these tiny, tiny branch pulmonary arteries just coming in here. Here's your aorta, and then coming down inferiorly, you see here are your tiny branch pulmonary arteries. And when you look on a color Doppler, on the arches, you can see here we have the ductal arch here, and then here, sorry, the aortic arch, and then here underneath is the tiny, narrow proximal insertion of the arterial duct. So what am I saying? I'm saying that tetralogy of Fallot at 12 or 13 weeks of gestation looks exactly the same as tetralogy of Fallot at 18 to 20 weeks of gestation. The same criteria, you make the diagnosis in the first trimester as you do in the second trimester of pregnancy. So I might just need to time skip these ones. And in terms of, in this case, just to share to you about looking for multiple arterial pulmonary collaterals is more challenging in the first trimester. So split image, showing four-chamber on the left-hand side, sweeping up to the three-vessel tracheal view. You can see that this is the trachea and that the aorta is sitting to the right of the trachea. But when you look at that, you are only seeing one vessel, a single sweep, with a split image with color. You're seeing a normal four-chamber and a single vessel on the three-vessel tracheal view. And then coming back to the four-chamber view of heart in the same fetus, by turning on slow flow technology, you can identify, even on power Doppler, you can identify it. But when you put on color, you can see the multiple arterial pulmonary collaterals coming off the aorta. So you can, in a sense, at a very early stage, prognosticate that you're looking at a tetralogy of Fallot with pulmonary atresia with multiple arterial pulmonary collaterals in the first trimester. And that's very helpful information that you have in your hand in terms of how to counsel patients going forward. So I'm going to skip through the differential diagnosis because we're covering that and in the questions that are coming up. And I'll finish up in the sense with just closing on how in terms of prognosticating in babies with tetralogy of Fallot. So in a sense, we've covered the genetics in the very first session, so I'll skip that. But I will say, what are the specific monogenic disorders that have been described? And Rabi touched on it exactly on the TBX and the Notch. Both of those genes specifically, Rabi, you mentioned in your talk, and both of those genes are specifically, in a sense, associated with tetralogy of Fallot. But you know what's very interesting? When you start reading into where we are going with all of this in the genetics, is we're reaching the point that when we start looking at the specific gene mutations that we can predict, in a sense, the clinical symptoms, or in terms of prognosticating outcome, because in terms of some gene mutations with tetralogy of Fallot carry a significantly worse prognosis when compared to the others. I know it's early days, but it is interesting reading. So the first is you do your genetics, you get a normal result, you put that aside, so now you're left with a baby with tetralogy of Fallot with pulmonary stenosis, and you're going to ask yourself, how's this baby going to go? Well, it all depends whether it is in the 30%. Remember, 1/3 of babies with Fallows will have an associated abnormality. So you really need to look closely to see what that associated abnormality is. And you're going to ask me, where do I look? There's no specific organ that is associated with Fallows. It's multi-organ. So the answer is, you look from head to toe. And then once you've ticked that and you've ticked that, then you're left with your case-specific findings. Then you say to Simon, okay, tell me, is there a Z score at 23 weeks of gestation with regard to the main pulmonary artery and branch pulmonary artery that you can tell me that this baby is going to be a pink Fallows or a blue Fallows? Well, it would be nice if life was that easy, wouldn't it? Because when you look at it, in a sense, looking at Fallows, it's not just the pulmonary artery, it's the size of the aorta. The smaller the pulmonary artery is, the bigger the aorta is going to become. So it becomes important not just to talk about Z scoring and determining the caliber of the pulmonary artery, is looking at the aorta as well. In fact, considering the ratio between the two in terms of prognosticating. I'll make it very simple. In terms of everything that's been published on it, and I think one is what we all do is we look at the size of the vessels in terms of prognosticating outcomes, talking here in terms of the need, because you're asking, Simon, what are you talking about outcomes? You're talking about the need for early intervention. You're talking about not the baby that you send home that's blue and that comes back 6 months later as a single operation repair. You want to pick the baby that's going to be delivered, who's going to be blue, and is going to need early intervention. And that's what all these prognostications relate to. The second issue in prognostication is prognosticating whether there's a single operation repair or a multi-operation repair. I think for us as clinicians, one thing that's very easy for us to do is actually to look and see where there's forward flow in terms of the duct throughout the pregnancy. Because if you've got reasonable sized pulmonary artery and you've got forward flow to the arterial duct, that's a damn good sign for that baby with Fallows. But if you see bidirectional flow or reversible flow, well, then the evidence supports that really these are the babies that don't do so well. And this paper, which I absolutely love, is you do a scan at 21 weeks of gestation, and if you get a single reading of a pulse systolic velocity of greater than 87 centimeters between 19 and 20 weeks, or 144 between 34 to 34 weeks, 100% sensitivity and specificity. I said, my God, that's the answer to all the questions we ever asked. You just Doppler that and get a peak systolic velocity. The problem with that is nobody's ever reproduced that paper. It would have been nice. So I think at the end of the day, I'll finish by saying, if you actually look at a Tetralogía Fetal with pulmonary stenosis and look at the 30-year survival, it's 95%. I see it as a condition. If it's a pink Fallows, it's an single operation repair. It's one of those abnormalities that carries good prognosis. But you need to inform the patient in a sense. For many of these, or not for many, but for some of these, they require significant interventions. And if you look at it, the number of hospitalizations per mean interventions per patients who have Fallows, and what I'm talking about is second surgery, catheterization, electrophysiological treatment that's going to be required during their life, then that happens in babies with a significant proportion. And lastly, my last slide is, we're in a completely new world. We're in a world where we know what the outcomes are with Fallows, but we've got Fallows living in adulthood. And we've got Fallows that have got all sorts of problems. We've got Fallows who've got aortic root problems, heart failure problems, required increased monitoring, and they're fragmented because they fall between the stool of a pediatric cardiologist and an adult cardiologist. And there's a whole new specialty arising that has developed, and is primitive in the States, is actually adults who specialize purely in congenital heart disease for those who require it. Because the biggest problem in babies with Fallows is pulmonary regurgitation and all the problems that exist with that. And you know what? In terms of what does this talk mean for you going tomorrow morning, the single most important thing that your talk makes you going tomorrow morning is that image, looking at the 5 points. Continuity, the interventricular septum. Disappearance of the valve during ventricular systole, central position of the valve, laminar flow across the valve. Because if you see that tomorrow, your baby doesn't have any of the 3 abnormalities or 4 abnormalities that we're going to discuss today. The last thing I did before I finished up in this talk, I said, let me just have a look and say, if we tied our hands and did absolutely nothing for all babies with Tetralogía Fetal, I wonder what the outcome would be. And it's interesting reading because, I started looking at this and I found a 56-year-old presents with dyspnea on exertion with absolute classical Fallows. I had a 71-year-old presenting with mild dyspnea to the accident and emergency department. And it goes on and on. In fact, there's a whole series from China of unrepaired Tetralogía Fetal. So if we tied our hands and did nothing, it doesn't mean inevitable death in childhood for babies with Tetralogía Fetal. Thanks very much for your attention.